Great, thank you. All right, so I'm the odd one out in the tricuspid session, so I will try not to mention the tricuspid valve at all. Okay, so we have guidelines, right, for appendage occlusion, and they're not particularly strong in the recommendations, either the American or the European, at best 2B. So yes, you can go ahead and do it. There's not a huge amount of enthusiasm in the guidelines. That's sort of the summary of why that is. A little background, this is how we've often referred to the appendages, as these various forms. We can use fun things like windsocks and chicken wings and cactuses, but we're probably moving beyond that. When it was very echo-dependent in the sizing and characterization, we sort of generated all these terms. But now that we're almost exclusively CT-based, we tend to just measure what we need and forget those things. The devices, broad categories, endocardial approach, which are really what we use today. The Watchman Classic, we don't really use much anymore, but the Watchman Flex device, shorter, doesn't go as deep into the appendage, and of course the Amulet is the other one that was more recently approved. But just historically, we had these epicardial, endocardial approaches, things like the lariat, combined from inside and outside. Fascinating concept, a little scary in some of the risk profiles, and effectively not used anymore. So as we do the imaging for these things, a lot of how you land is critically important, so getting to the imaging importance of why we're there, whether it's transesophageal echo or ICE. The device has to be deployed parallel to the LA ostium. The shoulder protrusion is a big deal, and it should be less than 40–50% of the device height, and tilt is an issue. So as an example, this would be a non-ideal issue. So leak, one of the main things, and really the two principal issues of today are sizing, leaks, and thrombus. So the leak assessment, multiple views, typically by TE. The largest para-device leak is the one that typically gets documented. Historically, the relevant leak was greater than 5 millimeters. So if you had a jet width greater than 5 millimeters on color, that was sort of an unacceptable outcome. That's really started from the trial work. And then if it was bigger than that, you had to do something different. You change the device, or you plug it, or you don't generally leave a 5 millimeter or greater gap. But there are challenges in how you approach that. You can do it with 2D, you can easily do it with 3D. 3D is very fun to identify the location of the leak, and the color is very helpful. Amulet is slightly different in how it works and how it lays down. But the Amulet, interesting, was initially for the Amulet, which is a more contemporary device. The 5 millimeters in general became a 3 millimeter acceptance of what a paravalvular leak is, or a para-device leak. And finally, the PASS criteria. So this is just sort of the general background. How do we know that we're done with one of these things? You have to look at the position, the anchor, a tug test, the size, is it compressed sufficiently to hold on, and the seal, so getting to a device leak discussion. I'll give you this review, really comprehensive, really helpful, so if you want to sort of deep dive into any of these topics, I would send you to this interesting review. They sort of go through what are the critical issues of today in this sort of unresolved, after almost 20 years of commercial Watchman initially procedures. So the discussions around the efficacy. Do we really have enough data to be enthusiastic about just non-inferiority to oral anticoagulation? The device leak has recently gained more interest as we've realized that 5 millimeters is probably too lenient, 3 millimeters is perhaps too lenient, and that any device leak is actually a risk. And then device-related thrombus, which we're learning more about. So the principal trials, the main reasons we got here in this conversation were the PROTECT-AF, the PREVAIL, and the PROG 17, and really all of those were non-inferiority trials. So non-inferiority to warfarin, and to a DOAC. And the key findings were yes. This is one of the main discussion points of sort of a summary of at least the PROTECT and the PREVAIL data. If you look, you had a really a terrific win for the device in terms of hemorrhagic stroke, so that's simply not being on an oral anticoagulant, but a bit of a loss in terms of ischemic stroke. So why is that? Why do you still have, in fact, a slightly greater risk of ischemic stroke compared to an oral anticoagulant? And that's probably because of device-related thrombus, halt, if you will, and paravalvular leaks. So you sort of lose in terms of a hazard ratio of 1.7 and 1.4, but you have a massive win on the hemorrhagic stroke side. So there's a whole bunch of trials now that are either brewing, near completion, or about to be published. So in general, occlusion is not inferior to oral anticoagulation in carefully selected patients with non-valvular AFib, so that's generally the indication. But there's really no data to support the use of these devices in patients with absolute contraindications, which is actually how we do it often clinically. So in theory, they're supposed to get 45 days or even 90 days of anticoagulation after implant, but a lot of patients don't. They go straight to this device if you have a GI bleed, for example. All of these trials address a whole bunch of other questions. So what about if you've had a recent intracerebral bleed, if you're having concomitant pulmonary vein ablation, which of the devices that are now available should you be using? Which are they actually better? The device-related thrombus is a big deal. Now that we're doing CTs fairly routinely, and not just CTs for screening, but CTs in follow-up, even asymptomatic follow-up, these ideas of hypoattenuated thickening, and you can see different formats, pedunculated, protruding, less concerning with the flat sessile ones, high grade, low grade. So there's a whole nomenclature now on the CT, much like we're seeing in the transcatheter valve world. How do we identify and discuss in a systematic way the thrombus that can be associated with these devices? And in general, the incidence of device-related thrombus throughout the PROTECT AF and the PREVAIL, if you looked at all of it, the registry data was about almost 4%. So a non-insignificant amount of thrombus on these devices. Below the device, that's fine, that's what it's supposed to do. Above the device and congruent with the LA, that's a problem. Are there risk predictors for device-related thrombus? There are. Age, prior stroke, renal dysfunction is typical. Device procedural factors, did you leave a shoulder? Is the depth right? So these are sort of the operator characteristics. And really what therapy was used. Was it just an antiplatelet? Did they truly get the 3 months of anticoagulation they were supposed to? These are some of the discussions. One of the things we're learning again is not just TE where we started, not just CT, but increasingly use of these computational flow dynamics, trying to predict which size. So on the left is the same patient, size with two different devices in a CFD model. Which one has more protrusion? Which one has a flatter shoulder? The other patient on the right, two different sizes of an amulet. This little graphic up here represents sort of the PVL, a bigger PVL on the small PVL, paradevice leak. The larger valve has a smaller paradevice leak. So we're using this modeling now to look at landing zone, some interactions, the amount of overhang, and the amount of paradevice leak. So the leaks, and this is fairly interesting new data. This is looking at two this is a combination of the PROTECT AF, the PREVAIL, and the CAP1. So if you looked at any paradevice leak, so including those under 5 millimeters, which were initially thought to be benign, but in fact they're not benign. The freedom from events over 5 years is quite significant. So any paradevice leak is actually significant, hazard ratio of 2. And again, on the registry data here, very similar findings. So freedom from events is different as you look out through the days, a little over a year. So the paradevice leak is not benign, but what do you do about it? Do you plug them? Perhaps not. Do you anticoagulate them? Well, that was the whole point not to do that. And we don't have any sort of standard therapy or standard approach to these leaks. We know they're associated with adverse events. The treatment strategies are unclear. And this is sort of one of the major unknown discussions in this field today. So left atrial appendage occlusion is certainly a promising alternative to oral anticoagulation in selected patients with non-valvular AFib, and I think selected is the key. Its utility across the nation has clearly gone up. It's quite an easy thing to do from the interventional perspective. It's a tougher thing to do from the imaging perspective, not technically, but to be there and to be paid to be there or not paid to be there. Increasingly, I think the number's around 25%. Sites are using just ICE without a dedicated imager. A lot of progress has been made, but there's still a lot of questions in this field, and we need more randomized data. And I'll try to get us back on time. Thank you.